Hello, everyone. I'm Dr. Carmen Pugliafito, and welcome to Retina Synthesis. We have today with us Carl Regillo, who is Director of the Retina Service at the Wills Eye Hospital in Philadelphia. Carl, welcome back to Retina Synthesis.
Thank you, Carmen. Thanks for having me back.
We're going to talk today about TKI inhibitor for maintenance therapy for neovascular AMD. Used to be called EY-1901. Now it's called Durayvu, I think.
The name, yes.
Why are TKI inhibitors of interest in the management of neovascular AMD?
Well, TKI would be expected to give us an anti-VEGF-like effect because it's a small molecule that works intracellularly to block the effects of the VEGF receptors, in fact, all the receptors. So it's actually a true pan-VEGF blocker. And there could be even other pathways or other kinases that it's inhibiting that could also be of benefit. So it adds that mechanism of action, but it's a small molecule. And the downside is small molecules, if I injected it into someone's vitreous cavity, of course, would be gone in days. So it, in and of itself, doesn't have much durability. But the small molecule, however, is easily packaged in bioerodible polymers. And there's several different TKIs that have been packaged in this way as solid bioerodible inserts, for example. And that's what EYP-1901 is. It's vorolanib, a potent and specific TKI that's packaged in actually, it's a commercially available type of completely bioerodible, very well tolerated polymer. So that actually allows it to be sustained delivery, in effect, to give a therapeutic level potentially of at least 4, 6, or more months. So it's intended to be maintenance phase therapy and sustained delivery. So therefore, an attempt to decrease the treatment burden. And the way all these TKIs, at least thus far, or up to this point through phase 2, have been tested is in previously treated and typically high need or high frequently treated patients.
So tell us a little bit about Davio 2. It's been out for a while, but it was an important phase 2 trial. Tell us a little bit about its design.
Yeah, it's actually a really important one because it's larger scale. It was the first phase 2 study that was controlled, masked, prospective, and what it was EYP-1901 being tested head-to-head with aflibercept dosed in a typical maintenance phase fashion every other month. So a 3-arm study with 2 doses of EYP-1901, 2 milligrams and 3 milligrams, a previously treated patient population that was selected by the inclusion and exclusion criteria to be high need, frequently treated, and yet responsive. And all 3 arms were loaded or reloaded with aflibercept, dosed monthly for the first 3 months, and then 1 insert of EYP-1901, and then a primary endpoint approximately 6 months later. And then the control arm continued to get aflibercept. In all arms could get aflibercept based on pre-specified rescue criteria. So it was put to the test to see how it would stack up in a non-inferiority trial against gold standard every other month maintenance phase aflibercept. Primary endpoint, non-inferiority of best corrected visual acuity from baseline. And keep in mind, from baseline, these are patients that are well controlled but frequently treated. So BCVA at baseline in this study was actually quite good, 20/32, and mean OCT thickness in the normal range on average, as you would expect for patients that have been previously treated. And I can go into all these details too, because that's important, because for all the sustained delivery programs out there, gene therapy, TKIs, port delivery system, we're selecting previously treated patients, typically that have been well controlled or under control.
So how they've been pre-treated with aflibercept for 3 months?
Yep. And keep in mind, everyone that was eligible for the study had to have at least 2 anti-VEGFs of any type within a 6-month time frame and diagnosed at any point in the past. So some patients may have had wet AMD for a few years or up to about 6 months. So previously diagnosed, previously treated, and then all arms after randomization were reinitiated, I should say, or reloaded with the 3 monthly aflibercepts. In fact, on average, patients before enrollment in the study had mean annualized injection of 10. So these are super high frequently treated patients. We're talking averaging every 4 or 5 weeks.
So how many eyes were enrolled?
So each arm equally randomized, approximately 55 patients, 54, 55 patients. So good size, double masked, randomized prospective study.
So, and the endpoint was at 6 months.
Yeah, it was actually a blended endpoint, weeks 28 to 32, which was about 6 months after the end of that induction phase, which was also the point at which they got their single EYP injection. So it gave you a 6-month look at the durability and the performance in terms of how well it controlled the wet AMD compared to aflibercept.
So what were the results?
Well, the results were very favorable. The study met its primary endpoint, with both doses being non-inferior to ongoing aflibercept therapy with mean BCVA out to that blended week 28 to 32. In fact, it was a non-inferiority margin, which is typical now of wet AMD studies, of 4.5, and all 3 arms were within a letter of each other. So easily met. It was highly statistically significant in terms of both doses being non-inferior to aflibercept. And so you see nice steady BCVA. In fact, the BCVA at the primary endpoint was about a letter or within a letter of baseline. So patients were 20/32 at baseline and approximately the same vision 6 months later.
What was the need for rescue treatment?
So it was pretty typical for rescue in virtually all our wet AMD studies. It was anatomical and/or visual criteria utilized. So I'm going to say pretty typical, and often there's a combination. So, for example, one criteria could be 5 or more letters of vision loss from best in study with a 75 or more micron increase in CST, or it could be just vision 10 or more letters, or it could be just a CST change of 100 microns or more.
So how frequent was rescue needed?
That's a good one. That's important because obviously if the majority of patients were rescued, it would be moot, right? It would be of no value. But the good news is 6 months from the EYP injection, the majority of patients, over 2/3, were injection or supplemental free. I should say supplemental free. That is, the 2 doses of EYP, it was 64 and 65% of patients went 6 months from that EYP injection without needing any supplemental aflibercept injections. And even more so, it's not just could they go without injections, but it's also important to look at how is the burden decreased. We also looked at how many got 0 to 1 injections, for example, because if they got just 1 injection, it still would be a success. If a patient's going from every 4 weeks to only 1 or 2 injections in the course of 6 months, it's a big favorable change for them. And we're up over 83% or so of patients only needing either none or just 1 supplemental injection. And then another way to look at it is decreasing the burden overall by looking at the reduction in annualized treatments. So again, they were averaging 10 before the study, and the reduction was really quite impressive. 89 and 85% of 2 and 3 milligram respectively. That was the degree of treatment reduction that we saw in the study. So
These are impressive results.
yeah, it really points to good disease control and what the intention of such a product is to reduce the treatment burden in the highest need patients. I mean, you could put this in all comers and it's going to look really good, but to put it in patients that need aflibercept or any of the anti-VEGFs we use as frequently as every 4, 5, 6 weeks and be able to, over half, even 2/3, of course, going injection free over 6 months is pretty impressive.
So what are the next steps for Durayvu and neovascular AMD?
Well, for this particular product, I should add that the safety turned out to be fantastic. There are actually no serious adverse events related to the EYP product. There were a few that took place, but they were related to procedures, including the injection of aflibercept or paracentesis. And there were no cases of intraocular inflammation, which is really impressive. And that also points to the notion that this sustained delivery platform is actually already being used and well tolerated with steroids as the small molecules. So with an excellent safety profile, it is moving on to the pivotal studies. It's anticipated that the phase 3 trials will start probably by the end of 2024. Exactly what the design is going to be, a little bit up in the air right now. It's still being finalized, but chances are I'll be testing one or both doses of EYP injected compared to aflibercept. And I think some of the decisions that need to be made is whether we're going to stick to previously treated patients and or recently diagnosed patients or something like that.
Mm-hmm. So there's a chance that we might see this as a primary therapy?
No, because even if it's treatment naive patients, they're going to be loaded with anti-VEGF. Because sustained delivery may not actually perform well at the early phase when the induction, we're trying to get maculas dry, whether it be wet AMD, DME, and so forth. And again, the same goes for port delivery, gene therapy. To introduce them at the get-go, the levels may not be actually high enough. It may actually not be good enough. You may need the bolus super high doses that we get when we inject intravitreally a biologic.
You're the co-chair of the scientific advisory board at EyePoint. Tell us a little bit about this delivery system and drug for the treatment of diabetic retinopathy.
Yeah, so it was put to the test in DR without DME, and it didn't perform as well as expected. There were some hints of biologic activity. In fact, there was a bit of a dose response in terms of decreasing vision-threatening complications, decreasing 2 or more step worsening. So there were some hints of benefits. It just didn't seem to perform quite as well as what we're seeing here in wet AMD. And it can't be fully explained, but it could very well be that diabetic retinopathy in general requires higher levels of drug. It is a disease, of course, where is globally higher levels of VEGF. And so maybe it doesn't work as well in that setting. But I wouldn't necessarily translate I'm going to say, lackluster results in DR without DME that was seen in the so-called PAVIA study, phase 2 study with DR without DME. I wouldn't translate that to what we're seeing in wet AMD, and obviously the results are very different. And the phase 2 Davio study for wet AMD was very well conducted, good size, and statistics were very strong.
So, Carl, thanks so much for this insight into TKI inhibitors in the management of neovascular retinal disease, a very promising area.
It is. Thanks for having me.
Thank you.